All right. Thank you to everyone for coming out tonight. I'm excited to have many people joining us live via Zoom, live on Facebook, and I'm sure many people will be watching the recording of tonight's event. My name is Dan Brook. I use he, him pronouns. I'm an MD PhD student at Ohio State in the College of Medicine and the College of Public Health. I'm also in the College of Public Health Division of Epidemiology, and I'll be your moderator to tonight's panel, Worse Than Ever, Overdose Death in Ohio. So before I begin, as a student at Ohio State, I would like to acknowledge that the land that The Ohio State University occupies is the ancestral and contemporary territory of the Shawnee, Potawatomi, Delaware, Miami, Peoria, Seneca, Wyandot, Ojibwe, and Cherokee peoples. Specifically, the university resides on land ceded in the 1795 Treaty of Greenville and the forced removal of tribes through the Indian Removal Act of 1830. As a land-grant institution, we want to honor the resiliency of these tribal nations and recognize the historical context that has and continues to affect Indigenous people of this land. And without further ado, I'd like to begin by introducing Archbishop Marcia Dinkins. She is the Executive Director of Ohio Interfaith Power and Light. Archbishop Dinkins has organizing experience on the national, state, and local levels with a background in organizing on issues related to domestic violence, health and safety, education, jobs, and crime. Archbishop Dinkins holds 3 degrees in Associates of Arts from Oakland Community College, a Bachelor of Arts in Interdisciplinary and Women and Gender Studies from the University of Toledo, and a Master of Arts in Criminal Justice and Policy from Youngstown State. Archbishop Dinkins has also taught social justice workshops at Case Western, Bowling Green, and at the American Baptist Church's Leadership Academy. Without further ado, Archbishop Dinkins, the floor is yours.
Good afternoon. So I'm sorry, good evening, everyone. And it's pronounced Marcia, but I know everybody calls me Marcia. I would just like to take the time I've been asked to open the floor up or to set the atmosphere up with prayer. So whatever your position is or your stance, by all means, just get comfortable where you are. It is really I tend to close my eyes. You don't have to do it. But I would just ask that we just come and settle together in solidarity, one with another. To He who is all things wonderful, I would like to thank you for this moment in time where we are really addressing the truth and the consequences of what happens when people are overlooked, overwhelmed, and undersituated with resources. I'd like to thank you for the opportunity for the voices that are coming together in solidarity to liberate the hearts and the souls and the minds of the people. For there has been so much going on and so little done, but I thank you for the hands that are lifted to the plow today to push through, to press through in such a pressing and distressing situation. What I want to be thankful for more than ever is the fact that these are individuals who have come together with a cry for harm reduction on all levels, asking for more healing and less harm. And I am thankful today because we are love in motion. The greatest way to undo the harm is to let love be shed abroad, radical love. And so I thank you that this meeting is a meeting place for radical love in motion, that this is a time where we are seeing the highest form of love being poetically displayed, where billboards of love are projecting loud messages that we want to heal and we want to reduce the harm, that we are tired. We are not here to die for the cause, but to cause the things that cause us to die. So I thank you for the open hearts, for the loving hearts, for the tender hearts, for the ones who put forth effortless work day to day in such a painful way and in a painful place, that constantly are reminded that we were not called to death, but we were called to live. So today I am thankful for the warning message, for the clarion call and the call to action, that enough is enough. We will not, shall not see another person die, but we will make the declaration and the clarion call that they should live. Not another day will we proclaim that this is the worst time ever, nor do we want to continue to look at that the worst time ever is due to overdose in Ohio. So today, as we turn shoulder to shoulder, back to back, side to side, and join hand to hand, we come together in solidarity, making a declaration for those who cannot speak. Enough is enough. We shall stand and we shall fight and we shall be love in motion and in action. This is a movement, not just for one, not just for some, but for all. And we thank you for this. And this I pray. Amen.
Amen.
Thank you so much, Archbishop Dinkins, and I apologize for mispronouncing your name.
No worries.
So without further ado, I'd like to begin to just give a little bit of background about how we got to where we are today. So between 1999 and 2019, nearly 500,000 people died from an opioid overdose. Since then, it has risen above 500,000. And this problem is a multi-layered problem that occurred in 3 distinct waves. The first of which is associated with a marked rise in prescription opioid overdose deaths in the 1990s, primarily associated with overprescribing of prescription opioids. In 2010, we saw the second wave, which was a marked rise in heroin overdose deaths as prescribers decreased their prescription of opioids and individuals transitioned from prescription opioids primarily to heroin and increased injection drug use, which also led to the beginning of the infectious sequelae of injection drug use, a part of the now opioid syndemic or opioid crisis. And then in 2013, we saw a marked rise in synthetic opioid overdose deaths. Those are primarily fentanyl and carfentanil. We've also seen that many of those synthetic opioids have now begun to adulterate many of the synthetic or stimulants that are commonly used, such as cocaine and methamphetamine. And there have been discussions about a potential 4th wave that we're seeing, whether or not that is distinct from the 3rd wave, or whether that is just the 3rd wave with an adulteration of the stimulant products. So looking at these 3 waves over a time period, here we have the y-axis of the total counts of deaths in Ohio, and the x-axis we have the timeline from 1999 to 2018. The blue bars representing all opioid deaths in the state of Ohio. And we see the lines that represent the individual causes of these opioid deaths. The blue line representing prescription opioids, we can see from 1999 to about 2011, it's the primary cause of death due to opioids. And then we begin to see this uptick with the orange line of heroin in 2010, which is that transition from primarily prescription opioids to heroin and injection drug use. And then again in 2013, we saw this rise in synthetic opioids, where in 2015, synthetic opioids, again, like fentanyl and carfentanil, began to overtake heroin and also begin to infect other or adulterate other forms of stimulants, such as cocaine, methamphetamine, and several other forms of drugs, and even cannabis. So today we're in an overlapping series of epidemics, which are known as a syndemic. Those are those injection site infections, primarily, that began in 2010, viral hepatitis and HIV, which also began in 2010, sexually transmitted infections, and also, of course, substance use disorders. These are all connected through sexual networks, rising homelessness, needle sharing, and a lack of access to clean needles, and also comorbid substance use disorder. So that's a little bit of background on how we got to where we are today. And I'm looking forward to hearing more from the panelists about their views and updates from the Ohio Department of Health. So without further ado, introduction of our panelists tonight. Shay Dalrymple is the Harm Reduction Ohio Communications Director. Shay is a person with substance use disorder with extensive firsthand experience with intravenous drug use and the health problems that result from a lack of sterile syringes. Originally from Steubenville, Ohio, Shay graduated from Scripps School of Journalism at The Ohio University. She worked as a writer and editor for newspapers and now advocates for people who use drugs, for harm reduction practices, and for an end to the failed drug war. Jamie Eitan is an epidemiologist at the Ohio Department of Health. Jamie is an overdose epidemiologist with the Violence and Injury Prevention section. She's responsible for analyzing mortality and morbidity data to describe the impact of drug overdose on Ohio's population, and she was formerly a hepatitis surveillance epidemiologist at ODH. We're also joined by Sarah Mormon, the Violence and Injury Prevention Section Chief at ODH, who will be answering our live questions. And finally, Orman Hall. I apologize, Mr. Hall, if I've gotten anything about your bio incorrect. Orman Hall is the Glidden Foundation Visiting Professor at Ohio University. He was also the former director of the Ohio Governor's Cabinet Opiate Action Team, the director of the Ohio Department of Alcohol and Drug Addiction Services, and the manager of specialized dockets for the Supreme Court of Ohio. Mr. Hall was also the former executive director of the Fairfield County Board of Alcohol, Drug Addiction, and Mental Health Services, and he currently is working as a public health analyst and consultant for the Ohio High Intensity Drug Trafficking Area, and as a consultant to the National Emerging Threats Initiative. Without further ado, take it away, Shay.
Thanks, Dan, and hello to everyone. Thanks to Archbishop Deacons. I'm somebody that's lost a lot of people to overdose death. Many of my friends in the last 5 years have died as a direct result of overdose death, and many from fentanyl specifically. We can look at these numbers, like the recently released CDC number, I believe was 96,000 from March 2020 to March 2021 for nationwide. And it's just really important. I really want to emphasize how that number is misleading because it's a number. It represents a human toll. Each one of those people are people. And they potentially had hundreds of lives affected by each one of those losses. So you really can't even begin to quantify the amount of loss and the magnitude of the loss. I lost a friend very recently, about 3 weeks ago, and in a Facebook post about him, somebody had commented mentioning his drug use. And my immediate reaction was to hide that comment to sort of protect his family from having him be associated with that. When people die from overdose, we tend to say passed away or just not even acknowledge what the cause was. And there's plenty of good reasons for that. People don't want their loved one to be looked down on or to be remembered for that. They don't want the negative stigma. They don't want somebody to think less of the person that they loved and the person their son, their daughter, their father and mother, brother, sister, whatever, whoever it was. They don't want the loss to be diminished by that association with drug use. Because the grief and the just amount of loss it's unspeakable. But if we don't learn to speak about it as a society, it's not going to get better. We can apply Band-Aid solutions. We can win battles in harm reduction when we're talking about syringe service programs, hopefully eventually safe consumption sites, decriminalizing and regulating the drug supply, treating drug use as a medical problem instead of a criminal legal problem. So it's the hiding it that's killing people right now. We can look at these numbers, we can look at this data, and it is a poison drug supply, but we have things like naloxone available. We have support systems in place, but they're not good enough. They're not reaching people. The shame is too great. Like, if you're gonna use, you're gonna use alone, especially if you've been sober for a while, which means you have less of a tolerance, you're more at risk. But with each sober day comes this pressure to maintain that and makes you more likely to hide and use alone. So we have this self-perpetuating problem of stigma that is really, in the big picture, what's killing people more than the poison drug supply itself, which is a huge problem. But I'm just alive out of pure luck, and anyone currently using fentanyl or drugs that may contain fentanyl, which the data shows us they do, that's the only thing. If you use alone, then it's just pure luck, whether you die every single time. And I'm talking about hundreds of times I managed to survive. So I just really want to, I can't emphasize enough how big of a loss each one of these people are. We're talking about some of the best of us, artists, musicians, writers, talented, intelligent people that are gone. And it's just, it's an unbearable loss for our society, for our country, for just any of us that care about other people. So yeah, my own personal loss is what it is, but each one of those people have hundreds of people that love them, that feel like I do. So it's just, it's an unexplainable scale. And I just want to remember that every one of those numbers, that's a person. It's not just a statistic.
Great, thank you, Shay, so much. And I think that before I pass it along to Jamie, I want to open it up to our audience to just let them know that if you do have any questions, feel free to put them in the chat. And at the end, we'll do our best to get them passed on to the panelists. So next up, Jamie.
Hi, can you hear me now?
Yeah, we can hear you.
Okay. Waiting for the presentation to come up.
1 second.
As she gets this ready, I'll just say that today we'll be going over some of our drug overdose mortality trends, including preliminary 2020 and 2021 data. But I'm glad that this is following Shay's talk. I hope that going through these slides that people can really process that each of these numbers is a person, and these numbers are large. But thank you, Shay, for starting us off, and we can go to the next slide. All right, so a little bit of background on the data that we're presenting today. This is mortality data that we're looking at. This information is pulled from death certificates, and we're specifically looking at unintentional drug overdose deaths. So we're not including suicide or other intents. These deaths occurred among Ohio residents, and county is also determined by the decedent's residence. So that may or may not be the county where the death actually occurred. It's determined by residents. And then as a data note, coroners do have up to 6 months to complete their investigations and submit death certificates. Then those death certificates go through additional processing for coding, et cetera, before the data then finally comes back to us. So there is a lag when it comes to reporting these deaths. Mortality data for 2020 is technically still more preliminary. We're not expecting any changes this late in the game, but it has not been officially closed and finalized as of yet. And then, of course, 2021 data is being updated daily. And a few of these slides will be showing just the first quarter of 2021, because those first 3 months will be the most complete as far as the data goes. And then finally, at the bottom there is a link to our injury surveillance and data page where you can find the overdose reports for 2019 and previous years. And that's where the 2020 annual reports will be posted as well. We're also publishing monthly drug overdose reports that highlight preliminary data as well as some annual trends. And you can find all of that under the drug overdose reports tab on that page there. And I'm sure that we can put that in the chat. Next slide. Okay, so before diving into our data, we wanted to briefly go over an explanation of rates. I know a lot of people often have questions specifically about age-adjusted rates. So in public health, we often use both counts and rates to help describe the burden of an injury or illness on a population. And rates for overdoses are calculated by dividing the number of overdose deaths by the population of whatever group we're looking at. And we get those population numbers from census data. And then we multiply that by 100,000, which is just a standard way of expressing it. So what you get then is the number of deaths per 100,000 population, and that's your rate. And by taking population size into account, that's what allows you to then compare between groups in a way that just looking at straight number of deaths doesn't allow for as much. So as an example, using finalized data from our 2019 report, we see that from 2014 to 2019, Brown County, which has a smaller population, had 129 deaths and a rate of 54.6 deaths per 100,000 population. That's a higher rate than Franklin County, a county with a larger population. They had a rate of 28.3, even though they had over 2,000 deaths during the same period. So rate helps to describe the impact on a population. Brown County had fewer deaths, but those deaths had a higher impact on their much smaller population. Whereas Franklin County had a higher number of deaths, but the impact on their population was less because they have a much larger population overall. And you'll also see the term age-adjusted rate a lot in the data that we put out. So that formula at the top is for crude rates. That hasn't been adjusted at all. But rates are often age-adjusted because the age distribution, which is the number of people in particular age categories, that can vary by geographic areas and populations. And we know, for example, looking at overdose demographics, that different age groups are impacted differently by overdose. We have a lot more deaths among 35 to 44-year-olds than in people who are 65 and older, for example. So age adjusting the rates ensures that differences in deaths between one geographic area and another, for example, aren't just due to differences in the age distribution of the populations being compared. You might have a much older population in one county compared to another county, and that kind of skews things and throws off your ability to compare between those populations. The formula for age-adjusted rates is a little more complicated than the crude rate formula up there, but it's basically just using weights to standardize populations. So it's just an extra step that allows for a more accurate comparison between groups. Okay, moving on to the data now. Next slide. This first figure here is showing the number and age-adjusted rate of unintentional drug overdose deaths by year. 2020 has now surpassed 2017 as our highest year for drug overdose deaths. 5,017 overdose deaths have been reported for 2020, with a rate of 45.6 deaths per 100,000 population. That's a 3% increase over 2017, formerly our highest year, and a 25% increase over 2019, the previous year. Next slide. All right, moving on to demographics, looking at county first. This is the average age-adjusted rate for 2015 to 2020. We typically combine years for maps like these because certain counties have such low numbers of overdose deaths that we can't accurately calculate rates for a single year. So combining years and taking the average rate allows us to compare counties more accurately. But using the 6-year range, we see that Scioto County had the highest overdose death rate during this period, followed by Montgomery and Gallia counties. Looking at 2020 data alone, the highest number of deaths, not surprisingly, were in our large counties, Franklin, Cuyahoga, and Hamilton, while our highest death rates were in Scioto, Gallia, and Meigs County. Scioto County was notably high this year with 148.9 deaths per 100,000. They also had the highest rate the previous year in 2019. Next slide. Now taking a look at drug overdose death rates by race ethnicity from 2015 to 2020. In 2019, the overdose death rate for the Black non-Hispanic population there in blue, that increased 28% and surpassed the rate for the white non-Hispanic population, who in prior years had had the highest rates of overdose deaths in Ohio. And that trend then continued into 2020. Meanwhile, the Hispanic population, there at the bottom in green, they continue to have the lowest rates of overdose deaths out of the groups presented here. And I should clarify that the category of Hispanic includes any deaths where Hispanic was listed as ethnicity, regardless of race. Breaking Hispanic down by all the different race categories would make the numbers too small to accurately calculate rates, et cetera. So that's why those deaths are combined into a whole just based on ethnicity. Next slide. And then this slide goes a little deeper and looks at race, ethnicity, and sex. Since 2017, Black non-Hispanic males have had the highest overdose death rates in comparison to other sex and race ethnicity groups. They're shown there in orange. And you can see that for 2017 and 2018, while Black non-Hispanic males did have the highest rates, the rates for white non-Hispanic males were very close. But in 2019, that gap really widened and has continued to increase into 2020. From 2019 to 2020, the rate for Black non-Hispanic males increased 26%, while white non-Hispanic males increased 23%. The rate for Black non-Hispanic females, there in dark blue, slightly surpassed the rate for white non-Hispanic females in 2020. Last year it was very close, but this year Black non-Hispanic females had a slightly higher percentage increase and did surpass the rate for white non-Hispanic females in 2020. And then Hispanic females there at the bottom in green, while they had the lowest overdose death rates out of the groups presented here, they had the largest increase in rate from 2019 to 2020 at 56%. Next slide. This figure takes a look at rates for our sex and race ethnicity groups and breaks them down by age. Here we did not include Hispanic males and females because the numbers were too small, but to the far right, you can see the overall Ohio numbers, and you can see that in 2020, 35 to 44-year-olds once again had the highest overdose death rate in Ohio. This was also true among white non-Hispanic males and females. However, among Black non-Hispanic males and females, the age group of 45 to 54-year-olds had the highest death rates. This is actually a shift for Black non-Hispanic males. For the last 10, 11 years or so, the age group of 55 to 64 had the highest rate among Black non-Hispanic males. Next slide. Okay, moving on to drug trends. One thing that we should note here is that these drug categories are not mutually exclusive. The majority of drug overdose deaths in Ohio do involve multiple substances, so an individual death may be counted in multiple drug categories. So for example, if a death involves both fentanyl and cocaine, it'll be counted once in the fentanyl category and once in the cocaine category. So these drug counts and percentages will not add up to the Ohio overall totals, just so you know. But looking at the number of overdose deaths involving these key drug categories, we see that fentanyl continues to drive the number of unintentional drug overdose deaths in Ohio. Fentanyl-related deaths increased 32% from 2019 to 2020. That was the drug category with the largest increase in 2020. And that was followed by deaths related to psychostimulants like methamphetamines. Those deaths increased 28% from 2019 to 2020. For heroin, there at the bottom in green, that was the only drug category that had a decrease in the number of deaths in 2020. Heroin-related deaths dropped 41% from 2019 to 2020 and now fall below deaths related to benzodiazepines, as well as deaths related to natural and semi-synthetic opioids like oxycodone and hydrocodone. Next slide. Okay, and now this is looking at the percentage of overall deaths that involve these drugs. Starting at the left with fentanyl, we see that the percentage of fentanyl involvement has continued to increase. In 2020, fentanyl was involved in 81% of drug overdose deaths in Ohio. For comparison, opioids in general were involved in 86% of deaths. Cocaine was involved in 25% of deaths, down from 30% in 2019. Psychostimulant involvement held steady from 2019 to 2020 and remained at about 21% of deaths in 2020. Heroin, again, continues to decrease and was involved in only 6% of deaths in 2020, which is significant given that if you look at 2015, heroin was involved in nearly half of Ohio drug overdose deaths. And then finally, the percentage of deaths related to benzodiazepines and natural and semi-synthetic opioids, what we would consider to be our prescription drug classes, these have continued to decrease and were both involved in 8% of unintentional drug overdose deaths in 2020. Next slide. Okay, so this figure shows the percentage of deaths that involved fentanyl, this time by drug category. Again, we know that the majority of drug overdose deaths in Ohio involve multiple substances. So we also look at drug combinations to get a more complete picture of current drug trends. So here we have our key drug categories looking at what percentage of those deaths also involve fentanyl. Moving from left to right, starting with non-opioid drug categories, we see that in 2020, 80% of cocaine-related deaths also involve fentanyl. 79% of deaths related to psychostimulants like methamphetamines also involve fentanyl. And deaths related to benzodiazepines, these had previously been holding steady in regards to fentanyl involvement at about 63, 64%, but that jumped to 76% in 2020. Looking at opioids now, of deaths related to natural and semi-synthetic opioids like oxycodone, hydrocodone, 67% of these deaths also involve fentanyl. That was the lowest percentage of fentanyl involvement out of these key drug categories. And then 83% of heroin-related deaths also involve fentanyl. That was the highest percentage of fentanyl involvement out of these drug categories. And we should emphasize here that this data doesn't tell us if individuals were aware that they were also taking fentanyl in addition to these other substances. We also don't know how these drugs were taken, if they were mixed together into one substance, if they were taken separately. But this does show us the importance of naloxone distribution, even to people who use non-opioids, because we see from this figure, we have a range of 76 to 80% of deaths related to our major non-opioid drug categories that also involve fentanyl. Next slide. All right, for these next set of slides, we're going to break down drug involvement by our sex and race ethnicity groups. This is the percentage of deaths that involve these substances. Fentanyl there in blue was involved in the largest percentage of deaths in each group. Black non-Hispanic males and females, to the far left, they had higher percentages of cocaine involvement compared to the other groups. That's there in orange. While white non-Hispanic males and females had the highest percentage of psychostimulant involved deaths. That's there in red. Next slide. And then this next slide looks at fentanyl combinations with other drug categories. There was a bit of a shift in 2020. In recent years, the combination of fentanyl and cocaine was involved in the highest percentage of deaths for each of these groups. But for 2020, fentanyl and psychostimulants were involved in the highest percentage of deaths for white non-Hispanic males and females. The combination of fentanyl and cocaine was still involved in the highest percentage of deaths for Black non-Hispanic males and females and Hispanic males and females. That's the orange bar there. However, you can see that the percentage were notably higher among Black non-Hispanic males and females for that particular combination. Next slide. Okay, 3 more slides to go here. These are all taking a look at our first quarter data for 2021 to see how things are shaping up in comparison to previous years. This slide is showing the overall number of unintentional drug overdose deaths by quarter for 2017 to 2021. For quarter one, there to the far left, it was 2017 that had the highest number of deaths when comparing these previous years. However, that was followed by 2021, which had 1,301 deaths in that first quarter. That was a 4% increase over the previous quarter, quarter 4 of 2020. However, we should again emphasize that this data is very preliminary, so we expect these numbers to increase. Next slide. Looking now at our drug categories, these are unintentional drug overdose deaths by quarter. 2020 quarters are in blue, 2021 is in red. From quarter 4 of 2020 to quarter 1 of 2021, the largest increases in deaths involved non-opioids. Deaths related to psychostimulants like methamphetamines increased 9%, followed by deaths related to cocaine, which increased 8%. Heroin was the only drug category with decreases during this time period. Deaths related to heroin decreased 8% from the last quarter of 2020 to the first quarter of 2021. Next slide. And then finally, we have number of deaths by race ethnicity, again by quarters, comparing 2020 to 2021. From quarter 4 of 2020 to quarter 1 of 2021, deaths among the white non-Hispanic population increased slightly at 3%. Deaths among the Black non-Hispanic population increased 11%, and deaths among the Hispanic population decreased 13%. But again, these numbers are preliminary, and we do expect a lot of changes between now and when that 2021 data is finalized. Next slide. But that is all I have for you today. Thanks for hanging in there. I know that was a lot of information. But again, please refer to our website for the monthly overdose reports and the annual reports for 2020 when they're published. We can probably put that link in the chat again for you. But these reports have all this information and more and are great resources to have. But thank you for having me. Thanks, everyone.
Wow, thank you so much, Jamie. That was a wealth of information. I certainly have left with several questions. And now on to our third and final panelist, Orman Hall. The floor is yours.
Thanks, Dan. I'm going to leave my camera off. I'm having some bandwidth problems. That way, hopefully we can avoid sort of choppy video on my PowerPoint. So with no further ado, hang on a second, I will pull up my slide presentation. Just want to verify that everybody's seeing my screen.
Yep, we can see it.
Excellent. Okay, let's move on to the first slide. Basically, I wanted to add maybe just a little bit of context to the very fine presentation from our colleagues at the Department of Health. What this slide does is it puts into perspective Ohio's overdose epidemic from the standpoint of the remainder of the nation. As I think most of us know, Ohio's overdose rate has tended to be towards one of the highest in the United States. That is certainly true in 2020. What we see here, and the red index color are those states that exhibit the highest overdose death rates in 2020. The states that are in the east are kind of the usual suspects, those states that have historically exhibited elevated rates of overdose death. The states along the southern border, Louisiana, New Mexico, and Arizona, tend to have slightly lower, but in 2020 we saw them pop up from the standpoint of also having elevated overdose death rates. This next slide sort of puts Ohio in perspective using sort of a bar graph approach. What we see here is that Ohio is 7th in the nation, again towards the very top in terms of overdose mortality. This particular table looks at some of the types of substances that are causing mortality around the nation. This is a US chart, compares 2019 to 2020. What we see here is that synthetic opioids, excluding methadone, which is primarily fentanyl, we saw a 55% increase nationwide in fatality associated with that category of drugs. If you go down one row, you see that psychostimulants with abuse potential, which is primarily methamphetamines, we saw a 47% increase in this particular category. And as our previous presenter noted, the vast majority of these deaths are co-occurring with fentanyl. I want to skip down a little lower to the cocaine category. We see a 22% increase there. And then if you look down at the category or row that is next to the bottom, we see heroin fatalities actually declined about 6% between 2019 and 2020. This next chart looks at mortality in Ohio as compared to the United States overall. What we see here is that Ohio's fatality rate for a number of years has exceeded the national average. I will say these numbers are based on CDC data. The CDC uses a slightly different methodology to calculate overdose deaths than the Department of Health. So these numbers don't line up precisely with the data presented by ODH. What I'm going to do now is sort of put overdose deaths in the context of other major disease states affecting mortality in the state of Ohio. These are just death counts over an extended period of time. from 2010 actually through 2019. And what you see here is that unintentional overdoses are the ninth category in terms of major causes of mortality. And then if you scan over to the last column, you'll see that there was a 163% increase between the first and last year of this period in the degree to which overdose deaths have increased, higher than any other major disease state. This particular graph just provides you with the same data in graphic form. You can essentially see where overdose deaths rank in terms of the continuum of major disease states. This next slide, or next two slides, looks at years of life lost. Essentially what we did here is we calculated the degree to which the major disease states are causing years of life lost in the state of Ohio. And the way we calculated that was we compared the age of death for each individual decedent in the state to how long they would have been expected to live if they hadn't died from that disease, based on the Social Security Index's period life table. So here's the data for that table. And if you scan down to the fourth category now, we see that unintentional overdoses caused a total of 1.19 million years of lost life in the state of Ohio, a staggering statistic, at least from my perspective. The final series of slides that we're going to look at in this particular series is the degree to which major disease states affect the average life expectancy of Ohioans. I'm not going to take the time to explain the methodology. I'll be happy to provide these slides to anyone who wants to look at this more specifically. But what we have determined is that unintentional overdoses decrease the overall average life expectancy of all Ohioans by about 10 months. From the period of 2010 through 2019. So just to kind of put all of this in perspective, if we just look at deaths, unintentional overdoses rank 9th in terms of causing total mortality. If we look at years of life lost, unintentional overdoses are 4th and account for almost 1.2 million years of lost life. But when we look at the degree to which overdose deaths affect the average lifespan here in the state of Ohio, if we didn't experience overdoses in our state, Ohioans would live in aggregate about 10 months longer. I want to spend the last few minutes on the Department of Health did a great job in terms of graphically displaying overdose death patterns. So I'm not going to spend a lot of time on this map, but this is average overdose death rates from 2010 through 2019. What we see here is that overdose deaths for the 10-year period tend to be concentrated in the southern part of our state. I want to spend the last few minutes of my presentation focusing on drug seizure data. This first slide looks at the mix of methamphetamine and cocaine seizures by region of state. What we see overall is that there has been a dramatic shift in our state from cocaine to methamphetamines. Not a big surprise for those of us that have been looking at these data. It tends to be across all of the major regions: Appalachia, the metropolitan areas, the northern Appalachian region, the rural counties outside of Appalachia, and the suburban areas. The suburban areas have historically been more oriented towards cocaine, and the rural areas were historically more, somewhat more oriented towards methamphetamines. But there has been a significant shift in terms of at least drug seizure patterns in our state, and methamphetamines have seen a tremendous increase over the span of the last several years. This next series of slides looks at the relationship between overdose deaths by type of drug and drug seizures. So what we're looking at here is drug seizures by month for a 10-year period, as represented by the blue bars, and deaths as represented by the red line. And as you can see, there is a very strong relationship between overdose deaths and drug seizures for the same type of drug. This particular graph looks at fentanyl. So the relationship between seizures and deaths for fentanyl is a staggering 0.944. For those of you who may not remember your statistics class, a correlation is a measure of association between two variables. So if you had one variable that was 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, and another variable that was 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, that relationship would be 1.0. In the real world, we never see relationships of 1.0. And for the most part, we don't see relationships of 0.944. So this next graph looks at heroin. What we see here, as previously noted by the Department of Health, was a pretty steady increase in deaths and then a decline in deaths. And we see precisely the same patterns in the drug seizure data. This slide is cocaine. We see deaths slightly lagging seizures for cocaine, a relationship of 0.788, which is still very strong, but not as strong as what we saw in the other two previous categories. And then the last graph is methamphetamines. And the methamphetamine data looks eerily similar to the fentanyl data, a very strong relationship of 0.951. So the takeaways, at least from my perspective, in terms of some of these data, and then maybe some other points here, if you step back and take a look at the National Survey on Drug Use and Health, what that data tells us is that there have been fairly modest changes in the number of people using illicit drugs in our society. But here in Ohio and increasingly throughout the United States, we're seeing dramatic increases in the number of people actually dying from overdose deaths. So what our research suggests is that changes in the lethality of the illicit drug market are the primary drivers of the increase in the number of people dying in our society. Fentanyl is maybe 10 times more fatal than heroin, and heroin is significantly more fatal than prescription opioids. So it is this shift, this change in the lethality of the drugs that people are being exposed to that accounts for the change and the increase in the number of people dying in our state and in our society. And that concludes my comments, Dan. Thank you.
Great. Thank you so much. And thank you to all of our panelists. I do want to let everyone know on Facebook Live that we are still tracking the chats. So if you do have questions and you're not here with us on Zoom, I do have some of these Facebook Live questions from our audience. And I, again, want to remind anybody live on Zoom that feel free to drop your question in the chat box. You can either chat it to me directly, or you can chat it to Amanda Lynn, and she will get it to me. So I do have a couple questions that I want to get asked, but I really want to focus on some of the audience questions that I've received because I think they are really interesting. The first one is really, and these are questions directed at anybody willing to answer them. We've had a lot of discussion about cocaine and meth and the relationship between cocaine and meth and fentanyl and some of the adulteration. I mentioned in the introduction that there's the potential that we're in the fourth wave, or that we're seeing the beginning of a fourth wave of some people are calling it polysubstance use, some people are calling it a stimulant use wave. Does anybody think that this is a fourth wave, or like I mentioned in the introduction, does it seem like fentanyl is just leaking into everything else? And it could be just, accidental that it's getting into everything else, or potentially it's a part of polysubstance use in some way.
And I know that Sarah was going to answer questions, so I might defer to her first if she has any thoughts. And then I can follow up, or we can do it vice versa. Sarah, do you have any thoughts?
Well, it's difficult for us to really say in the data. I think one of our best sources, maybe we can drop this in the chat as well, as the Substance Use Monitoring Network that Ohio MOS actually goes out and speaks directly with people who use drugs. So there's a little bit better information from that we can glean from that. I feel like, personally, I feel like it's a lot of fentanyl and people don't know what they're getting in their drug supply. I'm just not certain that there's a marked shift to the polysubstance use between cocaine and methamphetamine. I just personally don't know. But it's one of those things that at Health, we've been trying to get some campaigns started up to really talk about the fentanyl adulterating our drug supply. And we've started an OH Against OD campaign. It's taken a while for us to get it up and running, but we do have a lot of resources available out on our website for that as well. And different ads directed towards both habitual users and recreational users. So trying to reach those audiences in different ways and reach them where they're at.
Dan, I think Sarah makes some really good points that I pretty much agree with. And by the way, it's funny, when you were making your opening comments, I was pinning fourth wave prior to you mentioning that the fourth wave was a possibility. So I personally think that we are in a fourth wave, and the fourth wave obviously is the contamination of the stimulant supply with fentanyl, and the national data would suggest, or what we're seeing, or what we appear to be seeing in the national data, is that fentanyl is starting to cause mortality in states that previously have not seen overdose deaths. So if that's an indication, and maybe Dennis has some thoughts about this too, but that would suggest to me that it is, for the most part, unintentional, at least on the part of the user, and that the fentanyl is beginning to spread through the stimulant and cocaine supply in states that have previously been less affected by fentanyl and opioids. So this would appear to be a broader trend that is probably going to cause increased mortality around the United States, unfortunately.
I don't know, Dennis, do you want to hop in there? Shay, I'm also going to leave the floor open for you.
I'm interested to hear what other people think. I do think it's a fourth wave because the first three were all opioids. And this is the first one that's broken out of opioids into stimulants. And it's caused marked changes in the demographic groups who are dying. So it depends how you label it and try to understand it. But I myself subscribe to the fourth wave theory. The waves do overlap. But if you think about the standards of the first three waves, prescription opioids, heroin opioids, fentanyl opioids, what's happening now is markedly different than either of those three waves.
This is Sarah with ODH. Good call, Dennis. I just wanted to kind of throw in there that it really depends on how you're going to define a wave, and what you just described, it definitely is markedly different, like you said.
Just wanted to jump in for a second there. I agree that there's also a fourth wave, but just from personal experience and the people I know, there are differences. With cocaine, I think that it is an accidental adulteration of the drug supply and people not knowing what they're getting. When you look at meth, I think it tends to be more of a polysubstance use thing, because each one of these drugs is its own animal, and people use for different reasons. But what it really shakes down to is just the cheapness, the availability, the amount of fentanyl in the market is what's causing the rise in overdose deaths. No matter how you look at it, no matter how it's getting into people's systems, that's what's killing them.
And I would just add that what's going on now, I think, is more complex a little bit than went on before. Is, heroin replaced OxyContin for obvious reasons, and then fentanyl made opioids more potent. But right now, I think everyone's got a theory, but we don't really know why meth and why stimulant overdose deaths, or whether it's speedballing or goofballing, or people don't know, or often hear like users will take opioid to chill after like using for 2 days or something. So it's intentional. And I think it's a combination of all those things. And we really need to survey to see how it divides up. In addition, if you talk to people who run syringe programs, especially in the southern part of the state, a lot of people are injecting meth. Whereas 20 years ago, when meth was popular, there wasn't a lot of injecting. So a decent number of opioid users have switched to meth, partly because they will tell you they perceive it as safer. Whether that's true or not is separate. And so I think we have like 5 or 6 major contributors to meth in particular, and cocaine to a lesser extent, that we really have to tease out. And what makes it complicated is it's going to be all of the above in different proportions.
So with that, so if we do believe that it's now fentanyl and overdose deaths in general kind of are creating a more complex population that are overdosing, do we have to change our the way that we operate with our harm reduction practices? Do we have to rethink how we're distributing naloxone? I think as a healthcare trainee, when I ask patients, do you use any drugs? And they say cocaine, meth, even cannabis, I would never think twice about saying, oh, let's prescribe you naloxone. Let's give you a take-home naloxone just in case, But looking at these numbers, I would think I'm going to, everybody's a candidate for naloxone if someday they might come in contact with it. Really, anybody should be prescribed naloxone because they could come in contact with somebody overdosing. And so do we have to rethink, how we're distributing our naloxone, how we're where we're placing our syringe service programs, if this is something that we want to, reach out to a wider population? I'm especially thinking about those racial and ethnic disparities and overdose deaths that are now widening. Certainly, our approach needs to change if the population is changing.
So I think Sarah is a good person to answer this because ODH has made some really good efforts recently.
Yeah, thanks, Dennis. So we've recently started to, I don't think naloxone in our state at this point is, naloxone should be given to anybody that's at risk for overdose, and that includes anybody with a substance use disorder. So, and, from our perspective, naloxone needs to be in the hands of everyone who needs it. And I think we've done a better job at the state, making sure we're getting into those settings where we can find high-risk people. We started up a grant program that is trying to reach people through the syringe service programs and through jails and different settings where we know people are going to be at higher risk. So we've already been kind of watching where this is going and making sure that we've expanded naloxone distribution past that. In terms of the syringe programs, I think that's something that we just need to understand more. I do feel like those mobile units that I hear about are wonderful and get a lot of outreach into the communities. And I do think it's something that we need to continue to work on, especially from the state level.
I'll speak just a little bit, like Harm Reduction Ohio is the largest Project Dawn program. Thank you, Sarah. We'll do about 30,000 kits this year. And I don't think that we do a very good job in reaching meth and cocaine users, partly because it's hard. And Ohio has done quite a fine job in reaching people struggling with opioids, whether it's through medication-assisted treatment and syringe programs, but meth users are a lot more detached from the system, and stigma is a lot higher. And if you go to an emergency room, Dan, where like the police officer is there for that meth user who, is wired up. So it really requires sort of like creating whole new systems that don't exist to both educate and to make contact. And Orman's son, who's a doctor at OSU, actually has some really good ideas on this, creating like safe smoking kits and safe use kits for people who use meth. Because right now, like meth users have no reason to contact Harm Reduction Ohio or a health department, whereas an opioid user would have a reason for that connection. So I think, as odd as it sounds, giving something of value to this at-risk population, more than 1,000 meth users are going to die this year, way more than heroin users, and similar with cocaine. So we're almost about half of people who are dying in Ohio are stimulant users. So we need to, as harm reductionists in the state, need to give them something of value so that we can give them something of value.
And I've kind of jumping off that, I've got an audience question. Is there a class system within the community of people who use, like, is one drug more stigmatized than another, and are resources kind of equitable? I know from a healthcare perspective, we have great treatments for opioid use disorder, not such great treatments for people who use meth or cocaine for that matter. And so I definitely think, from my perspective, the resources are not equitable because our research hasn't reached the same level that we do with opioid use disorder, but I'm interested to hear what our panelists have to say.
I think this is for you, Shay.
All right. There definitely is a class system involved. People don't look at cocaine users and meth users the same. Words like junkie or tweaker can be thrown around when you're talking about a meth user, but somebody who uses cocaine every weekend in the bathroom of the bar is just fine. And this is a problem that is very complicated and hard to address because, like Dennis was saying, like we were saying, there's not a lot of treatment options for meth users. There is no easing the withdrawal. There is not a lot of medication-assisted treatment. And the damage that it does is different in a lot of ways from other drugs. So like Dennis said, there are just systems that don't exist right now that we need to put in place. And the other thing that's really important is we need to start treating people with substance use disorder and people who use drugs on an individual basis. There are no two that are exactly alike, and there's no answer all questions. So while there may be a class system sort of involved where people are looking down on certain kinds of drugs, it sort of highlights the difference and the different needs of these people and the different, like looking at the statistics, who is doing what and why. And a lot of the time it has to do with poverty and access to programs to help.
This is Sarah. I'll just add that from the public health prevention standpoint, it's really daunting too, because, naloxone gave people a lot of hope. Having naloxone on hand can save, friend, family, loved one. But with the stimulant use, not having those medications that we can we've started whole programs in emergency departments to offer people medication assisted treatment when they're ready for it. And we don't necessarily have those options for stimulant use disorder. So from a public health prevention standpoint, it's just overwhelming to think about what direction we'll need to go to respond to this. We've still got the naloxone when, if it's adulterated with fentanyl, and we'll keep that up, but it's one of those longer term issues that, to your point, Dan, I agree, it isn't equitable.
Great, thank you. Orman, I saw you unmute.
Yeah, I don't have a whole lot to add. What I would say is that one of the complicating factors here is that we, as Dennis alluded to, is we really don't have an in-depth understanding of about why people are using methamphetamines and fentanyl at the same time. So if it is intentional use, then many of those people could benefit from buprenorphine and methadone. If it is unintentional use, then prescribing those agonist opioid medications would probably not be appropriate. All the more reason for us to develop a deeper and more complete understanding of the factors that are driving this co-occurring use that we are currently seeing.
Great. The next question I think is probably directed towards Orman in the drug seizure data. This one comes from the audience. Is it true that most of the United States gets the fentanyl from Ohio? If so, do we know why it is, or is it just proximity?
No, that's really not true. It is true that Ohio has that Ohio's drug supply has been contaminated with fentanyl for much longer than many states around the country. Fentanyl is growing everywhere, but fentanyl hit Ohio early and hard. But fentanyl is coming across the southern border, and it's also coming from China. And we don't know specifically why Ohio was hit hard and early. We can hypothesize about that, but that is true. We did get hit hard, and we did get hit early. And unfortunately, the patterns that we've seen here in Ohio for a while, we're beginning to see in other states.
Great, thank you. We've got a really interesting audience question that I'm very interested. I think it's probably directed more at Sarah and ODH, but I would be interested in everybody's response. So the audience question is, if we look at heroin overdose data in recent years, it would infer that public health initiatives aimed at awareness and harm reduction have had great success. However, in aggregate, the trends in overdose do not show improvement. Should we therefore look at or does the data infer harm reduction strategies aimed at single substances will fail? I think this is kind of assuming that people are intentionally switching from heroin to fentanyl versus potentially getting fentanyl instead of heroin when they think they're getting heroin. But I'd be interested to hear the response. I think this is a particularly interesting question.
It's Sarah. I'll try and tackle that. You cut out in the middle of it though, so hopefully I can respond appropriately.
I can reiterate the question.
Yeah, could you?
Yeah, so if we look at heroin overdose data in recent years, it would infer that public health initiatives aimed at awareness and harm reduction have had great success. However, in aggregate, the trends in overdose do not show improvement. Should we therefore look at the recent initiatives as failures? Does this data infer harm reduction strategies aimed at single substances will fail?
Thank you. I think at this point, I think our reality has changed. Heroin, our initial efforts were focused mostly on opioids. And at this point, our drug supply is adulterated. 82% of our deaths include fentanyl. And it's just the reality that we're in right now. I don't think that there's a way that we do move forward without trying to address multi-substance use. I don't think that's possible at this point in the epidemic. Hopefully I answered that, and the other panelists, please chime in.
I just want to highlight, I don't think it's an intentional choice at all for people moving from heroin to fentanyl. It's about the market and it's about availability. And fentanyl is cheaper, it's more available, it's what people have right now. So no, I don't think anybody out there is saying, oh, give me that over that. It's just that heroin isn't here anymore. Like she said, it's an adulterated supply. We have a massive amount of fentanyl compared to heroin, and that's why people are using more of it.
I don't know that I have a whole lot to add, Dan. I think that our previous two panelists made some great points. But from a harm reduction perspective, we need to get really creative about discussing potential solutions to help move people away from fentanyl in our state. And I don't know what those potential options are, but we had 5,000 people die last year. So I don't know that anything should be off the table. It is a tragedy beyond anything that any of us could have imagined. And there has been a ton of good faith effort invested in dealing with this problem. So we need to think really hard, and we need to get really creative around looking for solutions that may not be currently apparent.
We have an audience question about some of the alternative strategies. I know, Dennis, you mentioned that Ormond's son is talking about clean smoking kits. And so an audience member asked if someone who uses coke or meth can get clean works at a certain service program, can they get clean cooking or smoking kits there as well? Is anybody familiar with?
It varies a lot by the syringe program. There's like 20, 21 different, and they're all locally run. So some don't even supply cookers, others supply cookers. So if you don't supply cookers, of course, if you're injecting, you're breaking the chain of sterility, but because of political reasons and compromises, I understand that Safe Point in Columbus gives out safe smoking kits. So I think it varies, and we don't really have good data on how widespread it is, but I don't think it's widespread in Ohio.
I think many of our syringe service programs and harm reductionists who are filling that role are working under the radar in this way, and they're funding it personally and through donations. So like Dennis said, it really differs from program to program, from lay distributor activist to activist. It's something that we need more representation. Drug users, we need to hear more of what they're needing and what they're wanting and where, and kind of just reacting to that in real time. But right now, there's not like a statewide regular system in place. It's just what's available in certain areas. Obviously in the urban areas, going to be better availability for these things. So we need to work on access.
So I think as a practical matter, a lot of funds have flown to the opioid crisis, and only in this latest round of federal funding with the State Opioid Response Grant have they opened it up to being able to be spent on stimulants. So a lot of the funds have been earmarked. So right now, I think the state and others are being more creative, because for the first time, there's an ability and funding to be more creative. So hopefully in the next 2 or 3 years, we'll see dramatic improvements, just as we saw with the opioid response and with the volume of naloxone, that Ohio has done a good job of increasing the volume because there is funding and possibility.
We have time for just probably one quick response. And we had a question about the motivation for drug suppliers to mix stimulants with fentanyl. Is that a motivation in that potentially people can get, addicted to a new substance? If they're using stimulants, then they'll start using other substances and continue to buy, or is it kind of an accidental thing, or do we just have no idea?
I think that's pure accidental thing. It's bad business to kill your customers. Fentanyl is just the cheapest, most readily available thing at the moment. And a lot of the mixing, I think, is just completely accidental. And then other times it's just cutting for the sake of economics. Like it said, it comes back to the market and the availability. If it's the most readily available thing, then yeah, it's going to turn up in other drugs.
I would respectfully disagree, maybe just a touch. I think Dennis made a great point earlier about this being a multifactorial problem. And I do think that that there are multiple factors here that are resulting in fentanyl contamination of both the cocaine and the methamphetamine supply. I think I think that it is true that fentanyl is less expensive, that there may be some efforts to mix it with other drugs from the perspective of getting people habituated to that particular product. But the evidence at the national level, where we're starting to see fentanyl spread in states that have previously not had significant numbers of opioid deaths, would suggest that there is some intentionality on the part of traffickers. And I think that's a factor. It may not be the only factor, but I do think there is evidence of intentionality.
I'll just say it's one of the most important questions, and we don't really know. Harm reductionists sort of tend to believe in the sloppy dealer theory, as it's sometimes called. You're mixing it on the same equipment, but there was a big meth bust a year and a half ago, 7 kilos in Columbus, from 3 guys from California. 7 kilos. Everyone thought it was meth. The dealers thought it was meth. The cops thought it was meth. When it went to the crime lab, there was no meth in it. It was only fentanyl. So I wondered, at what stage in the miscommunication did that happen? And what would be the public health consequences? It would be a lot of death. So the one thing that the data doesn't show us is, what is the drug sold as? What do people believe it is? We know what it is, what the actual chemicals are. And that's really an important thing that we still need to connect.
On that note, I want to thank all of our panelists, with this great closing discussion with future directions on where we can go and where we can investigate. I want to thank Archbishop Dinkins, Shay, Orman, Jamie, and Sarah, and Dennis for hosting this panel. Amanda Lynn for helping me with the IT portion. I want to close with one statement from, let's see if I can pull that up, from Jack Schuler. For those of you who haven't read This Is Ohio, I highly recommend reading it. It's essentially like a Dreamland style book about Newark. I first met Jack when I first met Dennis with my PhD advisor, Bill Miller. And so this is just a fantastic quote from an article that Jack Schuler had in The Atlantic. Grassroots harm reduction advocates' organizing principle is love. The kind of love is not admonishing people to pull themselves up by their bootstraps, and it's not the showy egocentric do-goodism primed for viral videos. Radical love is unconditional, and so is evidence-based harm reduction, which asks nothing from the people being helped, not even a tinge of reciprocity. As the preacher, writer, and harm reduction advocate Blythe Barno told me, radical love is incredibly ordinary. It's just, of course, this is how you act, but it's also visionary, a way of seeing what is possible for the person in front of you. So with that note, I want to thank all of our audience for great engagement. Thank you for taking the time to be with us today, and I hope everyone has a good night. Thank you.